Well, thank you, Professor Rook, and Sophie Steyer also for inviting me to address your group today. It's a fairly long way from Phoenix, Arizona to Stockholm. It takes about 19 hours each way, but it was a comfortable trip just the same, and I've spent my previous day here doing a little sightseeing, and you have a very beautiful city and setting to live in, so you're to be congratulated. So I'm here to talk to you about personality disorders in DSM-5 and beyond. So this is a very sort of future-oriented presentation. And I'm going to talk about classification, but I really want to underscore that the real purpose of classification, is to try to increase our understanding of patients with disorders. And so the better our classification can reflect the true nature of particular psychopathology, the better our patients will be understood and theoretically treated. So this is just a disclosure in case anybody here cares. They care a lot about this in America, who pays you, et cetera, and whether you're going to talk about drugs. I'm not going to talk about drugs at all. If I mention a drug, it's a mistake, since I don't think they're actually that useful for people with personality disorders. Now, Dr. Rook, Professor Rook mentioned that DSM-5 is unusual in a couple of respects. In the section 2, the main section of the manual, personality disorders, the 10 personality disorders, as they were defined with identical criteria, DSM-4, appear. So unchanged, really unchanged and unedited, the criteria for the disorders. So you'll find the three clusters, the cluster A, B, and C that you may be familiar with, the 10 categorical disorders, and personality disorder not otherwise specified, the residual class there. And the only really major change from DSM-4 to Section 2 DSM-5 is that there's no multi-axial system of diagnosis anymore in DSM-5, and that's a long story in and of itself. But so there's no axis 2. Anybody who's used to referring to personality disorders as axis 2 disorders is going to have to retrain their brains to delete axis 2. The other interesting thing about the giving up on the multi-axial system is it happened in the process of DSM-5 without almost any discussion at all, and certainly no scientific justification was offered or anything like that. It was just decided that they didn't want a multi-axial system and they would eliminate it. And it remains to be seen whether that's a smart decision or not a smart decision. One of the things that, well, I think that one of the beneficial aspects of a multi-axial system is that since personality disorders were first defined by criteria and put on a separate axis, which is now 35 years ago, goes back to DSM-3 in 1980, we've really learned a lot about personality pathology and its clinical significance. First, we've found out that personality disorders are very prevalent in clinical populations and in the community, 10 to 12% in the community, depending upon whether the patients are inpatients or outpatients. Minimum of 20% would have a personality disorders, maybe even up to 50% among patient populations. They're associated with high rates of social and occupational impairment. Now, and this is both with respect to role functioning and quality, role status and quality of functioning. So that means that people with personality disorders are less likely to be married, less likely to be in long-term relationships, less likely to be gainfully employed, and so on and so forth. But if they are in one of those roles, their functioning in that role, be it social or occupational, is lower. And this has been established, versus, a major axis 1, so-called axis 1 disorder, major depressive disorder, which has got its own functioning problems. But personality disorders, particularly the severe ones like borderline and schizotypal, are significantly more impaired than patients with major depression who don't have a personality disorder. We've also learned, again, in both clinical and epidemiologic samples, that comorbid, if you will, personality disorders result in slower recovery, more likely relapse, and greater chronicity over time for a variety of other mental disorders, including major depression, alcohol and other substance use disorders, and a variety of anxiety disorders. So these patients who are comorbid will not respond to typical treatments for those so-called axis 1 disorders in the fashion that you would think. And the problem is that oftentimes clinicians treating people with symptom disorders like major depression or anxiety disorders don't actually pay attention to whether the person has a personality disorder. And if they don't, then when the person doesn't respond to treatment, they may, for example, if it's psychopharmacology, change the drug or add the drug or something, and add another drug or do something like that, when in fact what the person has is an underlying personality disorder that is getting in the way of their full response and recovery, and unless and until that personality disorder is given some specific treatment, the course of the symptom disorder will not really improve. And finally, we found out that personality disorders are very costly to society. It's a high association with various kinds of criminal behavior, with substance abuse, with child abuse, spouse abuse, violence, so on and so forth. So personality disorders are a significant clinical and public health problem in and of themselves. So when we set out to revise personality disorder section in DSM-5, we obviously needed to pay attention to the existing classification and approach so that we were not doing what we call throwing out the baby with the bathwater. In other words, we weren't getting rid of things that had shown themselves to be clinically valuable just in order to pursue a new system. But there were also many, many problems with the DSM-4 3R and 3 categorical classification of personality disorders. There are some general criteria in DSM-4 and Section 2 DSM-5 for personality disorders that require that the person have cognitive, affective, impulse control, and interpersonal problems. These general criteria are very nonspecific for personality disorders. Many, many other symptom disorders could meet these criteria, including schizophrenia, forms of affective disorder, and so on. And there was no empirical basis for these, in fact. They were kind of made up because the group at the end of DSM-4 decided that they needed some general criteria. Wouldn't it be nice to have some? So let's sit down and spend an afternoon putting them together. But they're in the DSM-4, 5. Another problem with categorical approaches is excessive co-occurrence, or the comorbidity problem. If you get a diagnosis of a personality disorder, you are more likely than not to have at least one more personality disorder diagnosis. And if you give a semi-structured interview, like I have in some of my studies of personality disorders, that actually ask all the questions to addressing all the criteria for the 10 disorders, in a severely impaired personality disorder population, you might find patients who get 6 or 7 or 8 research-based diagnoses of personality disorders. So it doesn't really make a lot of sense to make 7 different diagnoses in a patient who you would consider to just have a really severe personality disorder. They don't have 7 independent conditions. There's also a lot of heterogeneity in any of the disorders that are identified with so-called polythetic criteria sets, where like 5 out of 9 are required, but no single one is required. So there are lots of combinations of permutations of 5 out of 9. In fact, there are 256 ways that you could meet the criteria for borderline personality disorder using the polythetic system. That's true of other disorders too. I mean, there are 5 of 9 for major depression. The new substance use disorder criteria set in DSM-5 requires only 2 of 11 criteria to make a diagnosis. So that gives you over 2,000 possible combinations. So the idea of within category heterogeneity plagues much of DSM, and the personality disorders are problematic in that regard. Inconsistency of criteria content. The criteria for personality disorders in DSM are mixtures. There are some criteria that are very trait-like. There are other criteria that are specific behaviors. And we've shown in a longitudinal study that the trait part of personality pathology is much more stable than the behaviors. A borderline patient may cut themselves or do various sorts of self-mutilating acts, but they don't do it on a daily basis or a weekly basis or a monthly basis or sometimes even on a yearly basis. So infrequent behaviors have the same kind of weight in the DSM-4 system as more persistent and prevailing personality traits. There's instability in personality disorders. PDs, one of the reasons for putting them on axis 2 originally was the thought that they were more stable types of psychopathology as opposed to episodic depressive or anxiety disorders. Well, it turns out that both of those assumptions are wrong. Personality disorders can change and do have fluctuating levels of pathology over time. We did a 10-year longitudinal study of patients with personality disorders, and not only our study, but other clinical studies and studies with non-patients and studies in the general population have all shown the same thing, and that is that personality disorders can change and really improve over time with some relapse. And then it turns out that some of the anxiety disorders are much more chronic than they were thought, and same with depressive. So the diagnostic thresholds, this whole idea of 5 out of 9 or 4 out of 8, those are also pretty arbitrary. The only 2 diagnoses in DSM-4, or now DSM-5 Section 2, that had any attempt to make their cut points scientific or empirical were borderline and schizotypal, and that was done in a study by Robert Spitzer, who was in charge of DSM-3 and DSM-3R in the United States. In 1979, he did a study to map criteria onto clinicians' diagnoses of borderline personality disorder and borderline schizophrenia that eventually became schizotypal, and he established these cut points. But since then, the criteria have changed, the cut points have never changed, and there are also these other 8 diagnoses. And the basic rule of thumb, I guess, among the committees that preceded DSM-5 were that if you were going to get a diagnosis, you should have at least half the criteria. So that's basically the whole rationale for the numbers. And I think clinicians know that the person who has 4 out of 9 borderline criteria is not that different than somebody who has 5 out of 9. There's nothing magical about making the threshold, and it's really a continuum of pathology that you're talking about, and this is just one more evidence about diagnostic thresholds not necessarily being appropriate. Poor coverage of pathology, even though there are 10 specific disorders, were and are in the official classification, the most common diagnosis is personality disorder not otherwise specified for people who don't meet the criteria for one of those 10. Poor convergent validity means that instruments designed to measure these disorders don't often show much correspondence, so that it means that they're kind of difficult concepts for people to operationalize, and so the instruments measure different things. You could look at 2 studies of borderline personality disorder. If they were diagnosed by different instruments, the overlap between the disorders might be fairly minimal. And finally, compared to trait models, categorical models really have limited predictive validity and clinical utility. So there are a lot of issues with the categorical approach, and that's really why we started out trying to change DSM into a more dimensional model. And the consequences of these problems sort of speak for themselves in that often the diagnoses were not used. Patients or people would write diagnosis deferred on axis 2. in the United States where the multi-axial system was required. They would underuse the diagnosis so that they would use that PD-NOS most frequently, or they were erroneously used. Sometimes the diagnoses were applied when the patient had, one or two criteria. So you'd have a patient who had mood instability and an impulsive suicide attempt, and you'd call them borderline. But shouldn't be the case. That's only two potential criteria. But no one actually took the time to do the full assessments in clinical settings that would be required. So the DSM-5 personality disorders work group set out to reformulate the 10 DSM-4 PD diagnostic categories. And we wanted to come up with a clearer conceptual basis of what PD pathology is, what really is a personality disorder as opposed to another kind of mental disorder. We wanted to provide a more efficient and effective approach to assessment, and we wanted to have a more empirically based formulation of diagnostic criteria for the PDs. And, a long story made very short, at the 11th hour, the Board of Trustees of the American Psychiatric Association decided that our proposal was too new and too different, and therefore it should be placed in Section 3 for emerging measures and models, although it was given this name of the alternative model for personality disorders, suggesting that it could be used to assess and diagnose patients with personality pathology as an option to the standard approach. So what is our alternative model? What basically does it look like? And so we were told that it was too complicated, and I've thought a lot about how to boil it down to a sort of a very simple kind of schematic. But first, I'm going to just review the changes in the alternative model. We've revised the general criteria for personality disorder. We've put in a new measure of severity of personality pathology called the Level of Personality Functioning Scale. We've required an assessment of pathological personality traits to go along with the severity assessment. And we've redefined personality disorders in terms of impairments in personality functioning and pathological personality traits. And we have a new concept of what we call personality disorder trait specified to replace personality disorder NOS. So that now if somebody doesn't meet the actual criteria, you would have some information about what kind of personality type or traits the individual had, rather than just the blanket and not that informative diagnosis of PD-NOS. So first, the general criteria for personality disorder. What are they? Well, we call this a hybrid dimensional categorical model, and it's not all that complicated, although some people did think it was. It starts out with this assessment of personality functioning, and I'll be talking about each of these component parts in the lecture today, but the model requires moderate impairment in personality functioning, along with the presence of pathological personality traits. And both of these assessments are dimensional. So there's a scale for measuring personality functioning, and each of the personality traits is also measured on a dimensional scale. And you add those two things along with some other standard DSM criteria that have been changed a little bit, but not that much: relative stability and consistency, and various developmental, cultural, substance use, other disorder, and medical exclusions. I mean, those are, and I'll show you a set of criteria a little bit later, but those are kind of the standard exclusion criteria from DSM. So the main idea here is adding these personality functioning and pathological personality trait models, and putting that all together, you get the revised general criteria for personality disorder. So first, the level of personality functioning. What is this? The level of personality function is based on a review conducted by Donna Bender, who's one of the work group members for DSM-5. She did a literature review of existing measures of assessing clinician-administered measures to assess personality pathology. What was out there already that was designed specifically to determine whether somebody had personality pathology or not. And she reviewed these instruments, looked for constructs that appeared in multiple instruments and constructs that could be shown to already have been reliably measured by clinicians in research studies. And she created this continuum made up of 5 levels of personality functioning, addressing key self and interpersonal elements. Now, the elements addressing what we call self-functioning are identity and self-direction. And identity is defined as the experience of oneself as unique, with clear boundaries between self and others, stability of self-esteem and accuracy of self-appraisal, and capacity for and ability to regulate a range of emotional experience. And under self-direction, we have pursuit of coherent and meaningful short-term and life goals, utilization of constructive and pro-social internal standards of behavior, and ability to self-reflect productively. Under the interpersonal domain, we have empathy and intimacy. Empathy being comprehension and appreciation of others' experiences and motivations, tolerance of differing perspectives, understanding effects of own behavior on others. And under intimacy, we have depth and duration of positive connections with others, desire and capacity for closeness, and mutuality of regard reflected in interpersonal behavior. So these 4 elements then are added together in the clinical mind, the mind of the clinician, and rated on a 5-point scale ranging from little or no impairment through moderate, serious, and extreme impairment. And in the scale, if you have a DSM manual, you can access the section 3 part of it, you'll see there's a scale in the back, and there are detailed definitions of what some impairment versus moderate impairment versus severe impairment would look like under the 4 different domains: identity, self-direction, empathy, and intimacy. So this is all spelled out, and this is a single global dimensional rating. So Donna designed this scale based on this literature review, and then another colleague, Les Morey from Texas A&M, was also on our work group, did a study in which over 300 clinicians, 337 clinicians, rated one of their patients on all DSM-4 criteria and all elements of the DSM-5 alternative model. DSM-4 criteria, by the way, were presented randomly, so that they couldn't have biases about what kind of pathology the person had or didn't have. And the DSM-5 elements were also presented in random order. And in looking at this scale, this 5-point scale, he was able to establish that a level of 2, moderate impairment or greater, had the best combination of sensitivity and specificity for a personality disorder. So if you looked at some impairment, obviously everybody with a personality disorder would have some impairment, but so would a lot of other kinds of patients who didn't have personality disorders. So that would have high sensitivity and low specificity. If you looked at severe impairment, well, very few people without a personality disorder have severe impairment, but you don't pick up all the people who do have, so you have lower sensitivity. So that if you're looking for a cut point on a scale to make a judgment about a diagnosis, where you would want to make a diagnosis, then you want to do the best balancing between sensitivity and specificity that you can. And that's why we empirically decided that moderate impairment or greater is the cut point for having potential to have a personality disorder. This also means that in DSM-5 Section 3, approach to PDs, that if you mastered this one scale, you would have a very good screening instrument for personality pathology in your patients. So if with this kind of sensitivity and specificity, you could do an assessment of this scale, this one item basically, and be in pretty good shape about whether the person was at high or low risk for having a personality disorder. And high risk, then you could go on and do more extensive evaluation. So the second part of the model then is the pathological personality traits. Now there are 5 trait domains. Some of you may be familiar or have heard of the 5-factor model of personality disorder. Well, these 5 trait domains in the DSM-5 model represent, if you will, the pathological ends of the 5-factor spectrum. So negative affectivity corresponds to 5-factor neuroticism. That is generally pathological in its own right. Detachment is the opposite of extroversion, if you will. Antagonism is the opposite of agreeableness. Disinhibition is the opposite of conscientiousness. And psychoticism isn't really the opposite of openness, but it's needed in the model to account for disorders such as schizotypal. But there are these 5 domains in the model, and each of them has underlying trait facets, more narrow trait personality traits, if you will. And originally the population of traits was 37, but it was boiled down in a community survey in a general population that involved over 1,000 contributors to a set of 25 reliably assessed, non-overlapping personality traits. So what do some of these trait facets look like within the trait domains? Well, under negative affectivity, we have traits such as emotional lability, anxiousness, separation insecurity, hostility, depressivity, submissiveness, perseveration. Under another domain, disinhibition, we have impulsivity, irresponsibility, recklessness, distractibility, and the absence of rigid perfectionism. So rigid perfectionism counts sort of negatively towards the disinhibition domain. So each of the domains then is defined. So relatively short, pithy definition of what the domain reflects. So negative affectivity domain reflects frequent and intense experiences of high levels of a wide range of negative emotions, such as anxiety, depression, guilt, shame, worry, anger, etc. And they're behavioral, like self-harm, and interpersonal, like dependency manifestations. So that's a definition for negative affectivity. Another example of a definition of a domain is disinhibition, orientation towards immediate gratification, leading to impulsive behavior driven by current thoughts, feelings, and external stimuli, without regard to past learning or consideration of future consequences. So each of the domains has, one of these definitions, and these things I think ring relatively true to people who work with patients with personality pathology, as things that characterize the various personality disorders that we now deal with. In addition, all 25 of the trait facets come with a short definition. So emotional lability, something you would see in borderline patients, is identified as unstable emotional experiences and frequent mood changes, emotions that are easily aroused, intense, and or out of proportion to circumstances. Parallel definition for impulsivity, something else you might see in borderline patients or antisocial patients, acting on the spur of the moment in response to immediate stimuli, acting on a momentary basis without a plan or consideration of outcomes, and difficulty establishing and following plans. So all 25 of the traits are arrayed in these 5 domains, and then given these brief definitions, and then they're rated on, again, dimensional scales from very little or not at all descriptive of the patient through mildly, moderately, and extremely descriptive. And generally speaking, a trait would count, if you will, as describing a patient if it was moderately or extremely descriptive. Then that would be something that would apply to a given patient. So what about the disorders? Okay, so Section 3 personality disorders. One of the things we decided fairly early on is that we weren't going to describe with criteria all 10 of the disorders. And I'll talk a little bit more about the rationale for that. But we focused on 6 disorders: antisocial, avoidant, borderline, narcissistic, obsessive compulsive, and schizotypal. And then, as I mentioned before, we have the trait specified, PD trait specified, that could represent the other 4 personality disorders, as well as any other presentations of personality disorder that one might find. So the reason that we focused on the 6 was we asked ourselves, and we did look at the literature, which of these disorders had a reasonable amount of data about either their validity or clinical utility. And looking at the publications from just the number of publications from 1994, which is when DSM-5 was published, to 2007 or 8, it was clear that the most information existed for 3 of the disorders, and those were, you probably would guess, antisocial, borderline, and schizotypal. And then there was hardly any data at the other end of the spectrum on disorders such as schizoid, paranoid, histrionic, virtually no empirical data at all to support, those entities. And then in the middle, there was kind of a modest amount of information about clinical utility or validity. So within that middle group, there was a little bit of picking and choosing, but taking a diagnosis such as avoidant personality disorder, it was surprising to me to find out that it's actually might not be surprising to you, but it was one of the most commonly made diagnoses in clinical populations, and also one of the most impairing. In fact, second to borderline, avoidant has in the literature is associated with more impairment than most of the other PDs. Obsessive compulsive doesn't have nearly as much impairment, but it is also a very commonly made diagnosis in clinical populations, and has been shown to be associated with very high costs of treatment utilization. So it has its own, importance. Borderline, of course, nobody would particularly disagree with. Some of the other diagnoses, paranoid, I said there wasn't a whole lot of information in the literature about paranoid. There were virtually no studies of paranoid personality disorder that didn't have some other diagnosis, interestingly. Either had an Axis 1 diagnosis and had paranoid symptomatology, or had another Axis 2 like schizotypal that had shared some paranoid symptomatology. There was virtually no study about paranoid personality disorder in the absence of some other kind of pathology. Other problems with something like dependent personality disorder. In clinical populations that, where people had done review studies, some studies would find that 30% or 25% of the patients had dependent personality disorder. In another clinic, that same percentage would be 2%. So if something has that variable prevalence in 2 kind of similar types of clinical settings, you wonder about how difficult it is to assess when somebody really has a dependent personality. So there are various reasons that we eliminated some and focused on others, but these are the 6 that we chose. And I'm going to now just walk you through the criteria for the one that probably interests most clinicians, which is borderline personality disorder. So thinking back to that model of the general criteria, impairment in personality functioning, pathological personality traits, when we get to the disorders, criterion A becomes the impairment in personality functioning, and criterion B becomes the pathological personality traits. And in criterion A, each of those parts of the personality functioning model, identity, self-direction, empathy, and intimacy, have a disorder-specific description of the type of impairment that they typically show, the patient typically shows. So Patients with borderline personality disorder in the identity domain typically show markedly impoverished, poorly developed, or unstable self-image, often associated with excessive self-criticism, chronic feelings of emptiness, and dissociative states under stress. In the self-direction domain, these patients would have instability in goals, aspirations, values, or career plans. And borderline is, by definition, the personality disorder of instability, so it definitely affects how they approach, life's goals. Under the empathy domain, borderline patients would have compromised ability to recognize the feelings and needs of others associated with interpersonal hypersensitivity, i.e. prone to feel slighted or insulted, as well as perceptions of others selectively biased towards negative attributes or vulnerabilities. And under intimacy, we would find the typical intense, unstable, and conflicted close relationships marked by mistrust, neediness, anxious preoccupation with real or imagined abandonment. Close relationships often views in extremes of idealization and devaluation, or alternating between over-involvement and withdrawal. So this is typical interpersonal behavior of a borderline patient that would be captured by the A criteria in the DSM-5 Section 3 model. Under the criterion B, pathological personality traits, we have a somewhat complicated algorithm here, but I'll explain it in a second. We have 4 or more of the following 7 pathological traits, including at least one of the following, which is number 5, impulsivity, number 6, risk-taking, or number 7, hostility. So first of all, from a theoretical point of view, within our group, a few people thought that borderline personality disorder could adequately be represented by emotional dysregulation, or in our terms, negative affectivity. But other folks in our group felt that no, that really wasn't a true representation of borderline, that there had to be some elements of impulsivity or some elements of antagonism, some additional personality traits that were beyond emotional dysregulation. And so, I'll come back to this in a sec. We did I think I'll explain as I'll take it in order, and then I'll back up and tell you how we came to that algorithm. So then the rest of the criteria are reflected in these C through G, which are the standard criteria that measure whether the person's impairments in personality functioning and personality traits are relatively inflexible and pervasive, whether they're relatively stable across time, onsets back to adolescence or early adulthood, whether they're not better explained by another mental disorder, and so on, with the various exclusions for substance and medical conditions, and also cultural and developmental processes. So these, again, are not major changes from DSM-4. The big changes are in criteria A and criteria B. So how did we arrive at any 2 of the 4 A criteria for a diagnosis? Well, again, we used that survey of clinicians who rated their patients on both the DSM-4 and the DSM-5. And at first, we were actually going to require 1 self-functioning criterion, 1 interpersonal criterion. But when we actually looked at the data, we found that the best combination of sensitivity and specificity was any 2. So for each of the disorders, 1 self and 1 interpersonal had reasonable sensitivity and specificity, but we actually wanted the A criteria to have higher sensitivities, and it turned out that any 2 was really preferable to 1 of either self or interpersonal. And so we ended up, based on this, this data set, deciding that the algorithm for the A criteria should be any 2 and not what we originally set out thinking it would be. Now, how do we assign the traits to the disorders? Again, this is a busy slide, but I'll point out a few highlights and try to illustrate how the traits ended up representing the disorders. Again, using the same sample of 337 patients who were rated on all the disorders and all the traits, we were able to look at the correlations between each and every trait and each and every disorder. And we were able to look at them both at the domain level, so the red bold numbers in bold are the significant correlations at the domain level, and then the black bold numbers are the correlations at the personality facet level. So you can see, for example, that antisocial personality disorder is made up of primarily traits in the antagonism and disinhibition domains with much lower correlations with the other three. In contrast to that, borderline has a very high correlation with negative affectivity, that should be, and lesser correlations with antagonism, but still significant, and disinhibition, but not much in psychoticism, and of course not much at all in detachment. And schizotypal looks like it's largely a combination of detachment and psychoticism. And so this is the way that the traits kind of are clustered within the disorders by these large domains. And then the individual traits within it, I mean, if you look at the black, bold black, for example, for antisocial, hostility, manipulativeness, deceitfulness, irresponsibility, impulsivity, and risk-taking, those are the 6 criteria for antisocial personality disorder, and those are the 6 criteria that have the highest correlations to the DSM-5 diagnosis of antisocial personality disorder. For schizotypal, the highest correlations are in the unusual beliefs and experiences, and eccentricity, and cognitive and perceptual dysregulation, as well as these 3 traits in the detachment domain. And so again, those are the 2 groups of traits that define schizotypal personality disorder. So in virtually all cases of those disorders, the traits that had the highest correlations ended up representing the criteria. Now, there are a couple of exceptions. If you look at narcissistic personality disorder, the 2 criteria that are assigned to that diagnosis are grandiosity and attention-seeking. But there are some other, fairly significantly correlated traits, particularly within the antagonism domain, such as manipulativeness, deceitfulness, callousness, etc. So those could have been added, perhaps, to the criteria for narcissistic personality disorder, but what happens if you do that is that you're basically making the diagnosis of narcissistic personality disorder into the diagnosis of antisocial personality disorder, that you would be increasing the co-occurrence of those 2 disorders and making them almost identical. Some people believe that narcissistic personality disorder is a minor variant of antisocial, but you wouldn't necessarily want to conflate these diagnoses. And so we made the decision, a conscious decision, not, to try to make these criteria sets as discriminating between themselves as we could be. So there are some instances where a highly correlated trait, we decided not to put into the criteria set. And then in terms of the actual algorithm using the traits, so we had decided that we would look at various combinations of traits, and we would look at the DSM-4 diagnosis in this 337-person data set, and we look at the prevalence, and then we would look at all various combinations of traits, including complicated algorithms that had traits from different domains, alternatives. This being the one that we eventually chose, require 1 from negative affectivity and at least one from disinhibition and antagonism. And the reason that we picked 4 or more, which is the rule for borderline, and making at least one be from disinhibition and antagonism, is that this prevalence is almost the same as that, which is the DSM-4, and this kappa of agreement is virtually the highest. This one is slightly higher, but we were also looking at making the discrimination with other disorders as low as possible and maximizing the relationship to functional impairment in order to choose a rule. And so we basically applied this complicated formula to all 6 of our diagnoses in order to be able to say that we had now some kind of empirical rationale for what the algorithm for making the diagnosis on the B criteria would be. And so the rules we developed based on those kinds of analyses, for antisocial, there are 7 criteria. Any 6 of 7 was the one that worked the best in terms of meeting, matching the prevalence for DSM-4 as well as the kappa and increasing the discrimination with other disorders and maximizing the relationship to functional impairment. For avoidant, it ended up being 3 or more of 4, one of which is anxiousness. For borderline, I just told you, is 4 or more of 7, one of which is from detachment or antagonism. Narcissistic, which only has 2 criteria, both are required. Obsessive compulsive, schizotypal again. So all of those, thresholds, diagnostic thresholds for the 6 disorders were empirically determined. A complicated system, well, the DSM-5 did a field trial in large academic centers, and one of the sets of disorders they were interested in was personality disorders. And in this field trial, this was taking people who did work at academic centers but weren't particularly trained in the new model or any of the criteria, particularly in DSM-5. They were basically looking at the new criteria for the first time and filling out information on patients that they were seeing in their clinics. Well, it turned out that, at least for borderline personality disorder, the kappa for the interclass kappa for the disorder was 0.54, considered good in our terminology. And it really was as good as the diagnosis of bipolar 1, slightly better than the diagnosis of schizophrenia, a lot better than the diagnosis of major depression, which didn't change at all. And it really only exceeded significantly by major neurocognitive disorder, which is dementia and PTSD. So, even with these fairly complicated personality functioning and trait criteria, experienced but relatively naive in terms of their exposure to the system, clinicians, these criteria could be applied reliably in the academic field trials. So what about clinical utility? So again, one of the criticisms that we faced was, were we being disruptive, to practice and to research? I mean, there's all this evidence out there now about various treatments for borderline and so on and so forth, and were we changing things so much that we would have lost the concepts on which all the research and training had been based? Well, as it turns out, the correlations between our diagnoses and DSM-4 diagnoses are really quite high. I mean, borderline was the highest, 0.803. Antisocial was high. Avoidant was high. Narcissistic was high. Schizotypal was okay, and obsessive compulsive was a little lower. But these correlations so the change from DSM-4 to DSM-5 based on these correlations would be less than the change that had occurred between DSM-3 and DSM-3R. In other words, there were more profound changes made between DSM-3 and DSM-3R that were really not protested by anybody. They just happened, but that was obviously a much more drastic change than we were making. So we felt, based on this data, reasonably confident that we had preserved the traditional constructs. We had just recast them in terms of these personality functioning and personality trait models that we felt were much more closely reflective of what we think about personality disorders than the criteria of DSM-4. And apparently so did the people who participated in the field trials. This is the personality disorder column. And if you looked at the number of people who thought that DSM-5 was moderately, very, or extremely more useful than DSM-4. Now remember, these people had worked with DSM-4 since 1994 and had been given the criteria for DSM-5 probably 2 days before they assessed their patient. But over 80% of people who participated in those field trials and made a diagnosis of a personality disorder thought that DSM-5 was moderately, very, or extremely more useful than DSM-4. And that was the third highest of all the categories that were examined in the field, in the academic field trial. And the same basically was true in the so-called private practice field trial, solo and small group practices. These were not academic clinicians. More than 80% found the new criteria moderately, very, extremely more useful in comparison to DSM-4. We did, as part of the survey, again, of the 337 patients, we asked those clinicians to rate the two systems on questions like how easy was it, how useful would it be to communicate with other professionals, communicate to patients, comprehensively describe your patient's personality problems, formulate effective interventions, describe the patient's global personality. And only in these first two did DSM-4 exceed some aspects of DSM-5. And you wouldn't be that surprised if somebody who had been using a system for 20 years told you that it was easier to use DSM-4 than it was to use DSM-5. But when it came to the trait model, it's kind of amazing that even with ease of use and communicating with other professionals and all of the others, the trait model was rated as more clinically useful by these clinicians than DSM-4. We also asked another question. So it's one thing just to say to somebody, well, how useful is it? It's another thing to find out whether the information predicts some of the judgments that they make about the person that would be clinically important. So remember, they didn't know exactly what diagnoses they were making. They were rating the criteria randomly. But we then put their diagnoses together based on their criteria ratings, and we correlated and predicted and did regression analyses on the clinician's judgment about the patient's composite social functioning, so social, occupational, and leisure functioning, risk composite, that's future risk for self-harm, criminality, or violence, estimated prognosis from poor to good, and level of treatment intensity from no treatment through outpatient, inpatient, and so on and so forth. And basically, if you looked at the DSM total, DSM-5 total, that's all aspects of the model, put those together, the predictions of these judgments was much more related to their DSM-5 assessment than it was to their DSM-4 assessment. So this is much closer to demonstrating that these constructs that were embodied in DSM-5 were used by the clinician in making these judgments, or could be used by the clinician in making these judgments. And if you actually took the two systems, DSM-4 and DSM-5, and you controlled for all the information in DSM-5 and then saw whether the information in DSM-4 added anything to these predictions, it rarely did, slightly to the risk composite. But if you did it the other way around, DSM-5 information, once you had controlled for all the information in DSM-4, you got these highly significant predictions above and beyond the information contained in those criteria. So you, again, could argue that in terms of incremental validity with predictions such as these, that the DSM-5 was much more related to the predictions than the DSM-4. So just again, looking to the future, want to mention some other models of personality pathology. You're going to, I guess, hear from Thomas Insel, and from the NIMH in a while, and I think he'll probably be talking about the research domain criteria. The NIMH is the place where most American researchers go to try to get grant funding, and that's you apply for grants to the NIMH to fund your research, and the NIMH has basically said, don't come to us with any grant about any diagnostic category, be it schizophrenia, major depression, borderline personality disorder. They really are not interested anymore in categorical diagnosis because they believe, as it says, that there's no rigorously tested, reproducible, clinically actionable biomarker for any psychiatric disorder at this point. And so they want to shift the emphasis of research towards underlying cognitive and motivational processes that cut across diagnostic categories, but are more basic to the kinds of things that where we might be able to find biomarkers or genetic patterns or so on and so forth. And so this group of what they call research domain criteria consists of 5 domains. One is negative valence, that's aversive types of conditions involving fear, anxiety, loss, and that could be anxiety disorders, depressive disorders, other disorders. Positive valence involving reward seeking and habit, influencing things like substance abuse and so on. Cognitive domain involving perception, attention, memory, and control. And then for our purposes, social processes, which involve things like affiliation, attachment, and understanding and perception of self and others. I mean, that is almost identical to the personality functioning constructs that we put into the personality disorders. And then there's a domain also about arousal and regulatory systems. But, Tom Insel believes, and the NIMH people believe, that there's this need to deconstruct current diagnostic groupings into these more fundamental pieces in order to kind of move research forward, and it's just not going to happen based on traditional DSM categorical diagnoses. And if you look at how the RDoC and the DSM-5 alternative model align, we have a bridge here. We have a bridge between traditional psychopathology and the RDoC in that the negative valence system is very much like our negative affectivity trait domain. Their positive valence system is the opposite of our antagonism domain. And under social processes, we have a trait domain of detachment, and then we have identity and self-direction and empathy and intimacy that align very well with understanding and perception of the self and understanding and perception of others. So again, I think, we think that there's a big opportunity here to go through the alternative model personality to tie the RDoC concepts in with more traditional diagnostic approaches. And you'll undoubtedly be hearing soon about if you haven't already, about the ICD-11 proposal for personality disorders. Again, it's a little different from ours, but if you're looking for similarities, you can certainly find them. They're diagnosing personality disorder on a continuum of severity. So they're having a one single personality disorder diagnosis that can be primarily personality difficulty, which is subthreshold for personality disorder, somewhat like our some impairment in personality functioning. And then they have mild, moderate, and severe personality disorder, kind of like we have moderate, severe, and extreme impairment in personality functioning. And then they have 5 broad trait domains, and we have 5 broad trait domains. And they align very closely, in fact. The only major difference is that they have an anancastic domain that has sort of obsessive-compulsive components, and we have the psychoticism domain so that we can make the diagnosis of schizotypal personality disorder. And they will have no PD types, no borderline, no antisocial, no type of any kind if this goes through. They will just have personality disorder and then characterized by combinations of these domains. So it's very, very similar in a way to, what we proposed. There's some differences, but, I think that these two systems moving forward will provide, much different kinds of information about personality disorders than what we get from current, categorical approaches. A word on measurement tools. To assess personality traits, there's something called the Personality Inventory for DSM-5. It's a 220-item self-report scale. The patient fills it out by themselves. They rate the traits on a 4-point scale from very false or often false to very true or often true. There's scoring for the 25 trait facets as well as the 5 main domains. And there's a informant version, a brief version, and a child version, full and brief. I might say that the child version is no different from the adult version. I'm not exactly sure why the APA put that in there, but it's basically the same. So there's this self-report that's been out, and there's a lot of research that's been accumulating about the trait model, how it relates to the 5-factor and other trait models, and how well it represents personality disorder pathology. And then we have a new semi-structured interview for the alternative model that we've just sent to the American Psychiatric Press, and they're agreeing to publish it. It's going to be a 4-module semi-structured interview with 1 module addressing level of personality functioning, 1 personality traits, 1 personality disorders, and 1 the complete alternative model. Now, this would be for clinicians and would require some experience with patients who have personality pathology and specific training in the instruments. So this will be probably available within 6 months for people who wanted to actually have a semi-structured interview that would address the various components of the alternative model. General features of the SCID-AMPD, we have a general overview that includes demographics, education, and work history, current and past psychopathology and treatment, suicidal thoughts or actions. And then we have a personality overview that has from 2 to 8 questions, depending upon the module, about perceptions of self and others and interpersonal relationships. So we ask the patient, how would you describe yourself? How would other people describe you? Who are the most important people in your life? How do you get along with them? How well do you think you understand yourself? How well do you think you understand other people? Those kinds of overview questions to get the person to be talking about the kind of material that you need to rate. But then we have multiple specific questions that rate every element of personality functioning, every trait, and every criterion, and then it can be scored on multiple levels. And there are, of course, detailed instructions for ratings and a user's guide. So to summarize, DSM-5 Section 3 advantages over Section 2. We think that actually the DSM-3 approach decreases clinician burden and increases clinician information. If you think about that level of personality functioning scale as a screening instrument, you have this 1-item test that you could apply to your patients that would give you a high likelihood of knowing whether they had a personality disorder or not. And if you went through all the criteria, there are 94 criteria for PDs in DSM-4. There are 54 criteria for PDs in Section 3. So we think it decreases the clinician burden and increases the information. The Section 3 decision rules, the diagnostic algorithms, clearly more empirically derived than what's in DSM-4 or Section 2. We think DSM-3 better addresses PD complexity and enhances understandings of patients' personality pathology. If patients have traits that are in the same domain, like antagonism, it's no wonder that those disorders often get diagnosed in the same patient. It's because they share these underlying fundamental features, and maybe there shouldn't be any categories. Maybe it should be just based on the fundamental underlying features. But at least you can see, based on the trait assignments and representations of the personality disorders, why certain kind of comorbidities frequently occur. The Section 3 approach is perceived as more clinically useful. That was both in the field trials and in our own 337 clinician study. And the Section 3 approach is more strongly related to clinical decision-making about functioning, risk, prognosis, and treatment assignment. So with that, I will stop. We have time for formal questions, and then I guess a little after we'll gather outside and have more informal discussion. So thank you very much.